Okay. I try to share with you today the work we did in the last year, in the last 5-6 years, about the minimal invasive treatment of the atrophic posterior maxilla. We all know that we are supposed to make decisions when treating our patients, and we know that the objective of our therapy, the primary objective, the primary aim is, of course, that the therapy is efficient. Then we try to select for our patients the minimal invasive option we can propose in order to lower morbidity for the patient, and also to save also economic resources, of course. But I would like to underline that there is a lot of talking in this period about minimal invasive approaches, minimal invasive techniques. I would like to underline that a real minimal invasive approach is the approach which ensures you the same results of other treatment methods, conventional treatment methods. Otherwise, we cannot talk about minimal invasive approach, but we talk about another thing, which is giving different results from the original technique we could apply. And talking about the topic of today, which are the guidelines to choose our therapy options when we have to treat with implants the posterior maxilla? Well, the guidelines in literature are really old. We have to go back to the 1996, the year in which there was the Sinus Consensus Conference, which whose results were reported by Ole Jensen in the International Journal for Maxillofacial Implants in the JOMI in 1988. And the consensus at that time was that the guide to choose the approach was simply related to the residual bone height of the bone crest in the area in which we wanted to place implants. And the guidelines at that time were to select a classic implant procedure if we had at least 10 millimeters or more than 10 millimeters in that area. It's not so common in the posterior maxilla to have more than 10 millimeters, but it happens sometimes. Then category B, if residual bone height was between 7 and 9 millimeters, the suggestion was to use a transcrestal, an osteotome technique with the simultaneous placement of implants. At that time, in 1996, the only available technique for transcrestal sinus floor elevation were the Summers osteotomes, as you know perfectly. Then, if we had less than 7 millimeters, we have to shift to a lateral approach sinus augmentation for this guideline. And in particular, with 4 to 6 millimeters of residual bone height, we could think to make a lateral sinus floor elevation with immediate implant insertion, or delayed if we were not able to find an adequate primary stability. And finally, the category D, in which there is very little bone, from 1 to 3 millimeters of residual bone height, in which the maxillary sinus elevation with lateral access was prescribed to be conducted without the insertion of the implant, which should be inserted after the consolidation of the graft. And this is what literature says about the decision making in the specific area. Why there was so wide attention about the residual bone height in 1996? Because we were working with different implants than today. If you look at this study was published in 2003 by Wang It was a study with the 6 years follow-up, and this studies concluded that this implant worked very well if the length of the implants was greater than 10 millimeters and long term. But we talk about machine implants, and with machine implants, especially in the area in which we are talking today, in posterior maxilla, the machine implant did not work very good. In fact, in this study, they found after 6 years, a failure rate about 20% of implants whose length was less than 10 millimeters. But we were in 2003, and the surface was machined. So things changed during the time. And the real change was the change in implant surface. So implants of reduced length were started to be used also in area in which they give unsatisfactory result previously. In fact, if we go to our days, 2019, this is the real last systematic review published about the use of short implants in the posterior atrophic maxilla. Is work by first author is Andrea Ravidas, my friend working at in Ann Arbor at Michigan University, and they considered 12 studies in this systematic review with a medium-term follow-up, comparing short implants, 6 millimeters or less than 6 millimeters placed in the posterior maxilla, compared with longer implants, more than 10 millimeters, placed usually in combination with augmentation procedures. And what they saw is that short implants, also in this area, showed less biological complications, of course, because the intervention is faster, is easier, and there is no a big morbidity for the patient. But they saw also less marginal bone loss after 3 years and reduce surgical time and treatment costs. So perhaps in 2020, in this era, we should consider the possibility to insert implant shorter than 10 millimeters also in this area. I want to share with you also this other study just to make you understand that short implants in posterior maxilla works very well, but you should have some surgical skills, some surgical tips, and you have to choose the correct implants. I mean, you deal with the area with a very limited bone density usually, so you need to achieve an adequate primary stability for your implants. So of course you have to use conical implants, because conical implants with conical implants it's easier to achieve a good primary stability, and you have also to pay attention to have a thread design with deep threads and which are able to entrap the bone between the threads and to find stability. But this one more thing is that you should reach also a cortical engagement on the sinus floor. Look at this study done and published 2 years ago by a Chinese group of authors, in which they analyze up to 5 years 53 patients with posterior maxillary implant. And they had one group of this patient in which they inserted both 10 millimeters and 6 millimeters implant with bicortical engagement. It means that the implant enters into the bone and engages also the cortical of the floor of the sinus. Well, up to 5 years, they found 100% survival in 10 millimeters group, but also 100% survival in 6 millimeters group. So very good results at medium term, 5 years. Let's have a look what's happening in the monocortical group. So in the group in which the implants were inserted without engaging the sinus floor. You see a bit worse is the situation for 10 millimeters implants. Is about 93% survival. So they lost some implants. But look what's happening with 6 millimeters implant. After 5 years, there is only 51 survival. So the absolute necessity to increase implant stability, short implant stability, by engaging the implant just in the floor of the sinus. It doesn't mean to enter into the sinus 5-6 millimeters, just 1 millimeters, no more than 1 millimeter. And you see what's happening. This is a 5 millimeters implant, a tissue level implant, with 2 millimeters, 5 millimeters of endoosseous part, 2 millimeters of a machine collar. You see, this is the moment of the insertion. You see the bicortical engagement and 1 millimeter, 1.5 millimeter of the implant into the sinus. And you see the situation after 2 years without any kind of augmentation, without any kind of grafting material, just inserting the implant with bicortical connection. You see the formation of some new bone also in the area in which the tip of the implant was inside the sinus. But the goal is not this millimeters of bone more. This is not significant. The significant part is that the implant was better stabilized by the cortical of the floor of the sinus. So the first thing that we have to learn is if it's really necessary to think about doing something to the maxillary sinus when we have at least 5 millimeters of more than 5 millimeters. Perhaps not. Perhaps in 2020 is no more necessary to have 10 millimeters of bone, as it was suggested by the Sinus Consensus Conference in 1996. But with nowadays technology, nowadays improvement of macro and micro morphology of implants, perhaps we can use in a reliable way also short implant when we have 5 millimeters or more than 5 millimeters of residual bone crest. Also because when you go to do something into the sinus, some kind of augmentation, I mean lateral, but also transcrestal augmentation, you increase dramatically the risk to have complications. Luckily, is not a common story, but it can happen. You should remember that when you enter into the maxillary sinus, you insert into the maxillary sinus a graft, you have always the risk, an increased risk to develop infections and to develop problems that you have to treat. I just want to share you a simple case report, but just to give you an idea of what can happen with the maxillary sinus floor elevation. This was a transcrestal maxillary sinus floor elevation. The patient was treated by my friend Rosario Centineri with the transcrestal sinus floor elevation with the insertion of a xenograft from the crestal access. No complication, no perforation of the membrane, everything seems okay. But after 1 week, the patient came back with problems, with symptoms like sinusitis, and unless Rosario prescribed her, of course, with antibiotics after the intervention. But you should remember that the anatomic landmarks of the maxillary sinus, you should remember that the top of the maxillary sinus is the floor of the orbit, and it is a very thin layer of bone separating maxillary sinus from the eye. So the problem was the sinusitis, but the patient had this kind of look 1 week after. This is a conjunctival chemosis, which was treated by changing the antibiotics by the ophthalmologists, and the patient had no problem. But just to make you understand that when you choose to do something into the maxillary sinus, you have the chance to have more biological complication, unexpected biological complication, than if you place a simple short implant. But luckily by my side, because I do a lot of sinus floor augmentation since 20 years, sometimes we do not have this 5 millimeters to place simply a short implant, but we are in a need to increase the available bone height in order to place implant. And I want to underline change in color, bone. We want to create something with our regenerative procedure which is helpful not only for radiographic purposes, just to show a nice case on the social media, I mean, but this bone, this should be something similar to bone. We know that it's not exactly bone, but it's a mix between a newly formed bone and grafting materials. But we need something, a tissue in which implant can osseointegrate. We need an additional support from this tissue. We just do not need a simple radiopaque material inside the sinus without any kind of effect on implant support. How is the bone forming into the maxillary sinus? Well, the new bone formation is a consequence of the surgical trauma. When we perform a sinus augmentation, both from lateral, from crestal approach, the detachment of the membrane from the sinus floor stimulates an inflammatory phenomenon with the release of cytokines and growth factor, like bone morphogenetic proteins, fibroblast growth factor, TGF-beta, and all the others, of course. And the new bone formation is a part of the healing process, because these cytokines and these growth factors are going to stimulate the differentiation of osteoprogenitor mesenchymal cells, which are going to synthesize bone matrix. And also, very important, these cytokines and these growth factors stimulate the neoangiogenesis to provide the regeneration area with blood supply, with oxygen, finally. So at the end, what we need to have new bone into the sinus, mainly two things. We need cells, and we need blood and oxygen to form bone. So any surgical technique we want to apply to the maxillary sinus should keep in mind which is the final aim: to provide our grafting material with cells and with blood. So we have to ask ourselves, which are the sources of cells and blood inside the maxillary sinus? Well, there are all the bony walls surrounding our graft. I mean, the lateral wall of the sinus, the medial wall of the sinus. The medial wall is the landmark between the maxillary sinus and the nose on the other part. The sinus floor, we have so three bone walls: floor, lateral, and medial. And the other thing which is in contact with our graft is the sinus membrane, the Schneiderian membrane. First of all, which is the role in terms of osteogenetic power of the sinus membrane? Where there are studies by Gruber, by Struy, done in the beginning of this century, which demonstrate that in animal studies, that the sinus membrane contains cells, osteoprogenitor cells, which are may constitute an additional source of bone-forming cells when we elevate the membrane. So, histologically, it was demonstrated that the membrane contains these mesenchymal progenitor cells. But which is the real significance of the contribution of the sinus membrane to the osteogenesis inside the sinus? we didn't know this until 2015, in which it was published a very nice study done by Rong on the dogs, in which they divided 3 groups of dogs. In the control group, they perform a sinus floor elevation with lateral approach, normal one, and they take biopsies after healing near the floor and in the membrane. In group 2, they use an ultra-thin titanium membrane to isolate the membrane from the graft. So in the group 2, there was no contribution of cells or of blood coming from the membrane to the graft. All the cells and all the blood and all the new bone formation derived from the bony walls and from the floor. And in the third group, they do the opposite. They, like in the image on the right, they isolated all the bony component inside the sinus with this isolating titanium membrane. So they covered completely lateral wall, floor, and palatal or medial wall of the sinus. So the graft received cells and blood only from the top, from the membrane, which was the only part allowed to be in contact with the grafting material. And what they say is that when the contribute coming from the sinus membrane was excluded, nothing special happened. There was, in any case, a good regeneration in almost all the grafted part, except in the part immediately near the raised Schneiderian membrane. But what we saw is in the third group, when it was excluded the contribution coming from the bony walls and from the sinus floor, leaving only the membrane to work to give the contribution in terms of cell and of blood, they found in the biopsies very, very little bone, just a few bone near the membrane, and all the rest of the cavity was completely filled only by grafting material, which was not converted. This, the findings of these studies were confirmed also by further studies by Jungner, also very recent publication done by our group, in which it was shown that the bone formation in the sinus floor elevation, lateral or crestal, starts at sinus floor and sinus walls, and goes over the implant surface. And the contribution of the sinus membrane is really, really irrelevant from a clinical point of view. It means I want to say that from an academic point of view, okay, in the membrane there are cells which can contribute, but the real clinical contribution is irrelevant. The real aim, so, is this, is that with whatever the technique we decide to choose, lateral or crestal, we need to place our grafting material in close contact with the lateral wall, sinus floor, and medial wall of the sinus. To do this, we need to have a proper sinus membrane elevation with any technique we want to use. If we use a lateral approach, if you want to use a transcrestal approach, the rules do not change. The rules, the biological rules remains the same. So the sinus doesn't matter which is the door we chose to enter into the sinus. He wants to make new bone to have the graft in contact with the lateral, the medial walls, and with the sinus floor. Because the sinus bone deformation into the sinus, as it was very well described in the study by Bus and Lechten in 2009, is a centripetal process originating from the periphery and going to the center. And the more we go far from the walls, from the floor, the less new bone formation we find. There are a couple of studies, one by Gustavo Avila and the other by Carlos Soardi, showing when performing lateral augmentation, a negative correlation between the width of the sinus, the distance from the buccal and the palatal sinus wall, and new bone formation. It means that the wider is the sinus, the less bone is formed during the healing period. And this is the study, in the particular of the study of Gustavo Avila, in which you can see that the first graphic indicates the vital bone of the entire sample is about 23%. But if we divide the sample in different sinus anatomies, we see that when we have a narrow sinus, less than 10 millimeters width, we have 31% of vital bone. If the sinus anatomy is a bit more large, from 10 to 15 millimeters, the quantity of new formed bone goes down, 25. And if we have a real wide sinus, more than 15 millimeters of width from the buccal to the palatal sinus wall, we find only 13% of new bone at the same time point after 6 months. About the new bone formation inside the sinus, we know really a lot about lateral sinus augmentation. This is a very recent meta-analysis made from Danesh Sani, in which he investigated all the article published in literature with histomorphometric analysis. It means with bone biopsies to see what is forming after bone regeneration. And he included 136 studies with more than 2,200 sinuses, really a huge amount of data. So we know almost everything of what's happening in new bone formation after lateral sinus augmentation with any kind of biomaterials at different time points. We know we have really a lot of information. But what's happening with transcrestal sinus augmentation? On one side, lateral, we have more than 2,000 sinuses analyzed with histomorphometry. If we browse the literature about the same information from transcrestal sinus augmentation, we see that since 1994, year in which Robert Summers introduced the osteotome techniques, we have only 4 studies making some kind of biopsies. And a couple of these studies are simple single case reports, and the other are little prospective studies. So we base all our knowledge about what is forming after transcrestal sinus augmentation on less than 20 biopsies. But one can say, okay, but it works perfectly, so we do not need a lot of data. It doesn't work like this, because it's a great variability in new bone formation. If you look at the results of this study, you see that the variability in new bone formation after 6 months is ranging from 7% to 75%. So it's a huge variability. But you can tell me, okay, we do not know what's forming into the maxillary sinus, but we know that it works because it's a consolidated technique. It is done since 20, 30 years, and it works perfectly. If we look to this systematic review meta-analysis done by Chalin in 2014, they show a survival rate after 5 years ranging from 92 and 96% with for implants inserted in combination with the transcrestal sinus augmentation. So you could say me, well, we don't know what is forming, but irrespective of what is forming, it works. But if you look carefully data, you can see that the great majority, the 90% of the included study, had residual bone height more than 5 millimeters. So what is really working? The residual bone height, like in the short implants, on what we are trying to create over the floor of the sinus? This is a big question. To evaluate this, we started in 2014 with my friends, the friends of my group, to evaluate, trying to evaluate really which is new bone formation after transcrestal sinus floor elevation. We started with a very little proof of concept case series study with only 8 patients, which was published in Implant Dentistry, but which allowed us to calculate a correct sample size to make a real study. And the real study was the one published in the Clinical Oral Implant Research in 2018 with 50 patients with 50 transcrestal sinus floor augmentation performs. And we wanted to, as Gustavo Avila and Carlos Suardi did for lateral approach, we would like to do the same thing to assess the influence of sinus width on new bone formation when making crestal approach to the sinus. So we perform in coupling together the results of both studies, 58 transcrestal sinus floor elevation without placing the implant, because we needed to do the biopsy after 6 months. And all this transcrestal sinus floor elevation when done as an inclusion criteria when the residual bone height was less than 5 millimeters. And we performed the biopsies and placed the implants, of course, after 6 months. And the biopsy was underwent histomorphometric analysis. And we performed pre-operatory, of course, but also post-operative cone beam CBCT, cone beam scan. We had a mean vertical bone gain of about 8.5, 8.6 millimeters. This image is one of the cases of the study before placing the implants. You see the good amount of newly formed bone. This is a kind of crestal sinus floor augmentation I like, because you see that the grafting material is in contact with both lateral and both palatal sinus wall. So is a graft receiving a good quantity of cells and of blood supply. And in all these 58 patients, it was possible to insert implants longer than 10 millimeters. This is one of the cases, a nice one, because on one thing, we had less than 3 millimeters of residual bone height, but the challenging thing was that underwood septa that you see just before the second molar. And we performed the crestal sinus floor augmentation, and after 6 months, we inserted the implant. You see there is also a good quantity of bone. This is a 11 millimeter Megagen implants, NE1 implant. And the result after 3 years is this. You see a good stability of the marginal bone, but the very nice results is the new cortical formed on the top of the grafted area. But the really important thing was the analysis of the biopsies, because as you can see, after 6 months, we found also in our patients a huge variability. There were patients with 60% of bone. There were patients without new bone formation, 0, no new bone formation. These are 2 samples. The 2 images on the top are representing a biopsy with a very good quantity of new bone. You see with the B, the purple area surrounding the particles of biomaterials is new bone. And you see the lower images, the 2 lower images, the B images, is a biopsy of another patient of these studies. And you see a lot of grafting materials, but absolutely no bone inside. Simply some fibrous connective tissues, but absolutely failure in bone regeneration. And we couple our histomorphometries with the CBCT images. This is one example. You see the CBCT and the biopsy coming from that sinus. You see that there is a good contact between graft lateral and palatal walls, and the result is a very good new bone formation, a lot of new bone inside this biopsy. On the contrary, you see another 6 months CBCT and bone biopsy, and you see a failure. You see a good quantity of biomaterials after 6 months inside the sinus, but this material has no contact with lateral, has no contact with medial bone walls, and the result is that it remained biomaterials. And you see the reaction of the membrane, which is hypertrophic, because the membrane interprets the graft as a foreign material because it was not incorporated by the tissue. It's just grafting material under the membrane, but not colonized by new bone. Which is the way to measure the width of the sinus? Well, the way by convention in literature, of course, you can have different values as the sinus wall are divergent, if you measure the width of the sinus in different places. By convention, in literature, it was decided to measure the width of the sinus at 10 millimeter side comprising the residual crest. You include in the measurement the residual crest, you go up 10 millimeters, and at that point you measure which is the X, which is the lateral buccal dimension of the sinus. So you can decide if your sinus is a wide sinus, a narrow sinus, or a medium sinus. And the results of our COIR study was the following. You see the split data. We had a general amount of new bone formation of about 21%. But if we looked only at the narrow sinuses, the sinuses in which the buccopalatal width was less than 12 millimeters, we find 36% of new bone after 6 months. If we go into medium width sinuses from 12 to 15 millimeters, the amount of new bone goes down to 13%. And if we go to really wide sinuses of this study, the sinuses which were more than 15 millimeters of width, we have only 3% of new bone formation. You see, in other terms, in this graphic, you can see on the x-axis the sinus width in millimeters, and on the y-axis the new bone formation in percentage. You see there is a lot of new bone formation until 11, 12 millimeters, but after 12 millimeters, really, really little bone is formed after transcrestal sinus floor augmentation. If we compare our data on crestal sinus lift with Gustavo Avila data on lateral sinus lift, we can see some similarities and some differences. You see that in narrow sinuses, less than 12 millimeter for us, less than 10 for Gustavo, the crestal approach, it works better because we have 36 versus 31, and our sinuses were a bit larger, 2 millimeters more, less than 12, not less than 10. But when the sinus goes larger, you see that in the large group, when Gustavo Avila has 13% of new bone in sinuses larger than 15 millimeters, we have only 3% of new bone with the crestal approach. Why? Because the biological influencing factors means the buccopalatal sinus width works the same irrespective of our technique, lateral or crestal. So we pay. The wider is the sinus, the less bone you have. But Gustavo, with the lateral, also in very wide sinuses, was able to elevate properly the membrane from the medial wall because he did it manually, of course, because he did the lateral. We weren't able because using the crestal approach, the biomaterial is not effective in elevating in a correcting way the membrane. So you have no bone contact between the graft and the bony walls. So we pay for crestal, of course, the biological problem of the bucopalatal sinus width, but also the technique which is not effective in reaching an adequate membrane elevation. So which are the solutions? Which is the solution of the problem? Of course, we should choose for our patient in a scale of increasing invasiveness. I mean, if we can place, if I can place a short implant, I place a short implant. If I need to go for a sinus augmentation, first of all, I want to see if I can do something less invasive. So I try to understand, to decide if I can do in a reliable way the transcrestal sinus elevation. Otherwise, I have to go to lateral. So this is the steps. And we published just in this month, it was published on International Journal of Periodontics Restorative Dentistry, this decision tree, in which we propose a rational way to decide the treatment in the posterior maxilla. At first, you have to look to the crestal bone height. If you have between 5 and 8 millimeters, you can go to short implants directly. If you have more than 8, of course, you go for a regular implant. If you have less bone, between 3 and 5, perhaps you can reach implant primary stability, but you need some augmentation. So to decide if you go to lateral or crestal sinus augmentation, you have to measure the bucopalatal sinus width at a height of 10 millimeters comprised in the alveolar cleft. If the sinus is narrow, less than 12 millimeters, the crestal approach would be effective, would be able to detach in a correct way the membrane. So you can go for a one-stage transcrestal sinus floor elevation. Otherwise, if the sinus is wide, more than 12 millimeters, you have to go to a lateral sinus augmentation to have the better result from the technique. And the same is also if you have less than 3 millimeters. If you have less than 3 millimeters, probably you are not going to reach primary stability, so the implants, it will be inserted in a delayed implant insertion. But in the same way, you can measure the bucopalatal width of the sinus. If it's less than 12 millimeters, you can go for a transcrestal sinus floor elevation without implant insertion. If it's wide, you have to go to a lateral sinus floor elevation to have a satisfactory outcome. So which is the take-home message? The take-home message is that at first, short implants treated correctly, I mean the correct implant design, the correct surgical technique could represent a valid minimal invasive option to restore the dentulous posterior maxilla, provided that you have at least 5 millimeters crestal height. If you have less than 5 millimeters, you can choose between lateral and crestal sinus augmentation because both of them are sufficient to regenerate a sufficient bone height, more than 10, 12, 13 millimeters, irrespective of the residual crestal height. You should remember that the transcrestal approach follow the same biological rules of the lateral technique. So you have to elevate correctly the membrane, and the only way to elevate correctly the membrane with transcrestal is to choose a narrow sinus, a sinus less than 12 millimeter width, and you have to insert an adequate amount of grafting material, the same amount of material which you would insert if you do that sinus with the lateral approach. And to choose between the two approaches, rational choice between lateral and crestal approach is dictated by the buccopalatal dimensions of the maxillary sinus, with the 12 like a magic number. I mean, all less than 12 millimeters crestal approach, more than 12 millimeter width, you have to go to lateral approach. Keep safe in this period, keep the social distancing, like these birds, of course. And I thank you very much for your kind attention. And I'm waiting, Rolandas, with your questions. Thank you.
Okay, thank you, Dr. Stacchi, for your comprehensive presentation. We have one question from the audience, from, let me see. So the question was about the material of the bone graft, what you're using to lift up the sinus. So is it what type of material you are using, and which one is the best for the long-term success? As I remember, the question was related.
Yeah. Well, of course, there is not the magic material. Otherwise, all the people in the world would use that material. So you have a lot of materials available, and each of them have some pros and some cons. The important is to choose the right sinus, the right dimension of the sinus if you want to go to crestal approach. And I prefer to use slowly resorbable materials, so it's okay with xenograft or synthetic biomaterials, with very little particles, because little particles allows you, in case of unwanted sinus membrane perforations, to be clear from the ostium of the sinus if the ostium is patent, without creating problems to the patient, some reactive sinusitis or something like that, which can happen if you use a large particle material. I'm trying also to use in this period, but we are making a couple of studies about this. It's very promising, but only when I place immediate implants after crestal sinus elevation, some collagenated materials that you can inject directly into the sinus, because the injectable materials will allow you to elevate the membrane and to make as grafting materials by themselves. But with this kind of materials, it is absolutely mandatory that you have to place the implant immediately. Otherwise, the materials will be, you lose volumetric stability during the healing period.
Okay, so Dr. Suleiman, if you're able to open your microphone, so please do that, and you will able to have a live chat with Dr. Stacchi if you prefer.
Okay.
Or if you're afraid to go live, so don't do that. Also, we have one comment from Lithuania, that Dr. Stacchi, you're always welcome in Lithuania, and we're glad to have you next time.
Thank you. Thank you. I was there a couple of times before.
All right. That's nice.
Very much.
So if we don't have more questions or any comments, so I would like just to thank you once again, Dr. Stacchi, for your brilliant presentation. And the next Megagen webinar will be next Wednesday on April, not on April. A second, it's going to be, yeah, it's going to be in, lost my calendar, sorry guys, in May 6th, yeah. So, and our guest speaker is going to be Dr. Maziar with his topic failure phenomenon from a different points of view. Also, if you would like to know more about special webinar program, just visit our webpage, www.imegagen.com, and you will find also there all of the recorded files of our webinars or live case discussions. So, for the third time, thank you for everything, and stay safe, stay strong. Everything will end soon. So thank you once again. Thank you for all the participants as well, and see you soon. See you next time.
Bye, Rolandas.
Okay.
Bye, everybody.
Bye.